Hi, this is Dr. Mario Del Cid from the Retina Group of Florida, and today I want to discuss with you some concepts involving macular degeneration. Macular degeneration, or AMD, is a major cause of vision loss in those over the age of 50. It gradually destroys macular cells, which are in charge of your fine central visual acuity. In this sense, it damages your ability to perform functions such as reading, facial recognition, and driving. It tends not to affect the peripheral vision, and complete blindness is rare. There's two types of macular degeneration. The more common dry form, which is about 80 to 90% of those afflicted with the disease. The dry form causes more gradual vision loss, and although at this point there is no treatment, there's various preventative measures. Unfortunately, the dry form may convert to the wet form. The wet form of macular often causes more dramatic vision loss. The good news is there's various treatment options that are available, and screening is key. We'll discuss some general eye anatomy. Of course, the front of the eye is where most of the refractive components of the eye are, including the cornea, the pupils, and the lens. The vitreous gel fills the cavity of the eye, and in the back, of course, is where we have the retina, the macula, and the optic nerve. The macula is the area of fine central visual acuity. On a histological section, the macula is quite complex. It's composed of various layers. Testing involving macular degeneration can be quite involved. Two main testing options are OCT and fluorescein angiography. OCT is a laser-assisted, non-contact, non-invasive test, whereas fluorescein angiography requires IV access, but it does give us some additional information, including real-time vascular flow and other information. In terms of OCT, again, reviewing the histological section of the retina, you see the various retinal layers. OCT gives us a sort of an optical histological section of the eye. Some regard this as a optical biopsy of the retina. Fluorescein angiography, on the other hand, is photographic in nature. This is a photo of a patient's retina, and fluorescein angiography highlights blood flow and other atypia, more often involving a macular area. This is a very normal looking fluorescein angiogram. In terms of dry AMD, the main culprit involved in vision loss is the formation of drusen. Drusen are deposits that form underneath the retinal surface. In fact, oftentimes form underneath the retinal pigment epithelium. Here on OCT, these bumps that form underneath the retinal pigment epithelium are in fact drusen. The photograph here highlights these yellow spots in the foveal area, which are moderate size, soft drusen. More advanced case of macular, you see these deposits become larger. And the fluorescein angiogram highlights these deposits. Vision loss from dry macular comes not only from drusen, but also from tissue loss. Here we see a geographic area of tissue loss involving the fovea. When tissue is lost and atrophy develops, unfortunately, there is significant vision loss. Here's another case, less dramatic, but similarly causing significant vision loss. With wet macular, one develops abnormal blood vessels underneath the retina. These vessels can cause leaking and bleeding near the center of vision. OCT showing subretinal fluid as well as a dome-shaped pigment epithelial detachment on the left side of the scan. Cystoid macular edema as well as subretinal fluid. Again, another picture of subretinal fluid. And in more advanced cases, a fundus photograph showing severe bleeding associated with a patient with wet macular degeneration. Milder case with a small hemorrhage. More pronounced case with more pronounced hemorrhaging. And here the fluorescein angiogram is very important. It shows an area of leakage right in the foveal area, which is consistent with wet macular degeneration. Symptoms can be gradual, however, more often they're rapid. It involves central loss of vision and distortion on the Amsler grid. Sometimes it can be completely asymptomatic, meaning the vision loss is mild. Of course, with macular degeneration, there is no pain, and at times the vision changes are subtle. Who's at risk? Well, those over the age of 50, those that have a family history, smokers, those of European ancestry, those that are obese, and those with a history of high blood pressure and high cholesterol. Screening is important. Routine, dilated exam, Amsler grid testing, and additional testing depending on findings can include OCT and fluorescein angiogram. In terms of treatments for dry macular, there is none. However, there are certain steps we can take to prevent further progression. They include eye vitamins. The ARIDS 2 formula was demonstrated in a large government-sponsored trial to prevent further progression of macular. Amsler grid monitoring, intake of leafy green vegetables and other antioxidants, smoking cessation, use of omega-3 fatty acids, fish oils, genetic testing for those at high risk. This is a somewhat controversial topic. For wet macular, prevention is similar to dry macular. However, once wet macular takes hold, this typically requires treatment. Older therapies included laser, thermal laser, and quote-unquote cold lasers such as PDT, which can still be used today. But more often the mainstay of therapy is intravitreal injections. These medications are what are known as anti-vascular endothelial growth factors, or anti-VEGF agents. They were initially investigated for cancer therapy, specifically colon cancer, and they work by inhibiting abnormal blood vessel growth. As it turns out, studies demonstrated that they were safe and effective in the eye, and currently we have 3 available agents: Avastin, Lucentis, and Eylea. Intraocular injections have become very common. Before 2000, less than 5,000 injections were performed a year. Between 2002 and 2007, more than 800,000 injections were performed within a year, and currently this number is well into the millions. Thankfully, they are low risk. They are not completely risk-free, but they are low risk, and in most cases, they are very effective. Follow-up is important. Patients with dry macular should be monitored depending on severity, usually every 3 to 6 months, though can be as infrequent as once a year. Again, this varies depending on risk. Wet macular patients are typically monitored and injected every 4 weeks. Following resolution of their edema or hemorrhage, the frequency of follow-up really varies depending on each individual patient. A question we oftentimes get from family members is, what should they do to make sure they don't develop macular? If they're younger than the age of 50, then eye vitamins are usually not recommended. I oftentimes recommend a screening eye exam, and I do recommend a healthy diet to include leafy green vegetables, omega-3 fatty acids, and I ask them to make sure they don't smoke. Thank you.